Finals SAQ5, Antiplatelet therapy and brain biopsy. The case. A 64-year-old man is scheduled for a stereotactic brain biopsy. He is taking dual antiplatelet therapy following the insertion of a drug-eluting coronary artery stent 6 months earlier. A. Explain the issues that may arise from antiplatelet therapy in this patient, 30 marks. Issues includes bleeding into the brain, bleeding from the scalp, in-stent thrombosis, and venous thromboembolism. Bleeding into the brain. If dual antiplatelet therapy continues, the patient is at high risk of bleeding as a result of the brain biopsy into a closed skull without access for diatemy to stop the bleeding. Hematoma leads to pressure damage on surrounding structures, causing brain damage, obstruction of CSF drainage, and seizures. Even aspirin alone is associated with a significantly high mortality risk in neurosurgery. Bleeding from the scalp may occur, but this is unlikely to be a significant issue. Premature cessation of DAPT renders the patient at significant risk of in-stent thrombosis, which carries a mortality of up to 50%. Cessation of ADP receptor antagonists may be associated with a rebound phenomenon, which in association with the stress response to surgery, increases the risk of thrombosis than usual in the perioperative period. B. Summarize the perioperative strategies to minimize the above issues, 40 marks. Multidisciplinary decision should be made amongst the cardiologist, anesthetist, surgeon, and the patient. The decision needs to balance the risk of premature cessation of DAPT against the urgency of the brain biopsy, duration of dual antiplatelet therapy. DAPT usually continues for 1 year after insertion of a drug-eluting stent. Factors that increase the risk of in-stent thrombosis and therefore mandate prolonged DAPT includes impaired renal function, ejection fraction of less than 30%, multiple overlapping stents, stents at bifurcations, diabetes mellitus, previous stent thrombosis, diffuse coronary artery disease, and ACS presentation. Options includes to delay the biopsy until planned time for DAPT has finished. Although 1 year is usually the minimum duration for DAPT after a drug-eluting stent, the risk of in-stent thrombosis reduces significantly after 6 months. This is only an option if the indication for brain biopsy is not urgent. The second option is to stop the ADP receptor antagonist for an appropriate duration prior to surgery. Ideally, continue aspirin if the surgeon and cardiologist are in agreement that the risk of stopping aspirin outweighs the risk of continuing. The surgeon is unlikely to proceed with biopsy with ongoing aspirin. The third option is to stop both the ADP receptor antagonist and aspirin a week prior to surgery. If the surgeon and cardiologist are in agreement that the risk of bleeding outweighs the risk of in-stent thrombosis, and restart aspirin as soon as possible after the surgery. The fourth option is bridging therapy, with short-acting GP2B3A inhibitors starting within 24 hours of stopping the ADP receptor blocker, restarting after surgery, and restarting the ADP receptor antagonist the day after surgery if satisfied with hemostasis. However, GP2B3A inhibitors are not licensed for this indication. Consider performing the brain biopsy in a center with on-site 24-hour interventional cardiology support if the patient is deemed at high risk of in-stent thrombosis and the ADP receptor antagonist and aspirin are to be discontinued. This is to attempt to mitigate the severity of any thrombosis that occurs. C. What are the specific contraindications and complications of a stereotactic brain biopsy under sedation? Contraindications includes lesions too small to safely target, coagulopathy, highly vascular tumor or lesion, such as vascular malformations, inability to comply with the procedure, for example, due to difficulties communicating, confusion, and movement disorders. Possible complications include hemorrhage, airway compromise, air embolism, failure to obtain diagnostic specimen, seizures, and CNS infection.